Could you imagine walking into the ER and seeing DNR tattooed across someone's chest? We're kicking off today's ethics and law review with some of the wildest and most misunderstood situations you'll face on the USMLE and COMLEX.
Honestly, the stories behind those situations are as dramatic as any medical drama on TV. I'm excited for this chat. Let's quickly introduce ourselves. I'm here to help you break down the trickiest legal and ethical dilemmas in medicine.
And I'm here to keep it practical and help you ace those exam questions. Today, we'll answer: who wins the living will or the crying spouse? Are tattooed DNRs legally binding? Plus, we'll tackle medical futility, reporting requirements, and cross-cultural care.
So, whether it's weird cases like vinegar massages for TB or whether a physician should accept that homemade cake, we're covering it. Let's get started with the ultimate showdown: living will versus emotional family member.
It never fails the patient has a signed living will, but the family's in tears, begging for something different. Who actually decides?
The answer always surprises people. Legally, that living will trumps, even if there's a friend or family member who swears, "Trust me, I know what they'd want." The document wins, not the drama.
Totally. And that's why it's so important to have those conversations early, not just for the paperwork, but to prepare families for the reality.
Which brings up a twist. What if there's no living will, but the best friend is adamant about what should be done? Unless they're the legal surrogate, their opinion doesn't override the written directive or next of kin hierarchy.
Switching gears, what about someone with DNR tattooed on their chest? Can you just follow that?
Nope. Tattoos aren't legal documents. You need a properly signed DNR, witnessed or notarized. There have been real cases where a tattoo led to confusion and even tragic mistakes.
And let's not forget, even with a legal DNR, physicians don't have to provide treatments that are medically futile. Advanced directives are powerful, but they can't bring someone back if there's truly no benefit.
Exactly. That's the concept of futility. If a treatment won't help, there's no obligation to offer it, no matter what's written or what families insist.
Now, let's dive into parental rights. Can parents refuse vaccines for their kids, or what if they want to opt out of a life-saving procedure?
That's where nuance comes in. Parents can refuse non-urgent things like vaccines because it's not considered immediate harm. But if a child's life is at stake, like refusing intubation or essential medication, the physician must step in.
So you'd even go as far as getting a court order if parents refuse something critical, like sickle cell meds or a life-saving surgery.
Absolutely. Protecting the child's best interests overrides parental autonomy when there's risk of significant harm or death.
Ethics gets trickier with cases like child cultural practices or minors who self-harm. When do you report? And when do you respect confidentiality?
Take cupping or coining marks on kids. Those aren't abuse, so you don't call child protective services. But with self-injury, even if there's no suicide intent, you're obligated to bring in parents or guardians, but ideally with the patient's involvement.
And what about consent? Only doctors, not nurses, should obtain surgical consent. Plus, for minors, only one parent needs to consent unless it's an emancipated minor.
And always clarify confidentiality upfront, especially with teens. Promise privacy, but let them know you'll have to speak up if safety is at risk.
Let's talk about implicit bias, like the persistent myth that Black patients feel less pain, leading to undertreatment. How do we counteract that?
It starts with awareness and self-reflection. Biases can be unconscious, so challenging our assumptions and striving for equitable care is key. Cross-cultural care is about respecting beliefs while avoiding stereotypes.
And when breaking bad news, don't jump to reassuring or sugarcoating. Start by asking the patient what they already understand. Set the stage for honest, empathetic dialogue.
Exactly. And when emotions run high, anger, grief, or confusion, open-ended questions, and a calm, listening presence can transform the encounter.
Here's a tough one. What happens if you perform a procedure on the wrong patient, like a wrong side mastectomy? How do we prevent these errors?
That's where methodologies like Six Sigma and the Swiss cheese model come in: systematic approaches to reduce human error to a minimum. Defensive medicine actually makes this worse by encouraging unnecessary testing out of fear.
So instead, things like clinical pathways and shared team goals help make care safer and more consistent for everyone involved.
And don't forget, every team member having a say, sharing a unified purpose is just as important in medicine as it is in a strong marriage.
We've covered a ton today, from living wills versus family wishes, to when cultural practices are okay, to the power of honest, clear communication.
Remember, 1. Written directives and competent patient wishes always come first. 2. Physicians must act to prevent harm, especially in vulnerable patients. 3. Being aware of bias and communicating with empathy makes you a better clinician.
If you're prepping for boards or real-world care, practice these principles with realistic scenarios. Run through cases. Ask yourself, who truly has decision-making power? And what's the most ethical action?
That's it for this episode. Thanks for listening. And remember, the best doctors know the law, but also know how to listen. See you next time for more high-yield medical topics.